Welcome. Welcome.
Yes.
Welcome, Eleanor.
So my job is really to introduce Eleanor, but I mean, I should say I do have a lot of things I could add to what Rick said about the rare disease funding landscape, which I think is pretty good at the moment, actually. And I chair one of the MRC boards, which has rare disease as its priority. And I'm also involved in the LifeArc funding. So I think it's always tough because there's so many rare diseases, but now is a really good time. So I can pick up on these things afterwards. The other thing to say in terms of what a patient group can do, I think Alström has an enormous advantage over a lot of other rare diseases already because of its co-ownership of the clinic. Because one of the questions which always gets asked is, have you properly involved patients or are you just paying lip service to it? But there is one thing which I think we touched on last year, which I think might be an advantage, and that would be looking to the James Lind Alliance for a priority setting partnership. So I know we already have a good sense from surveys of the group as to what the priorities of you all are. But this is a process which does this a little bit more formally with some professional help, and it has scientists and doctors and patients all there. And you have a look at sort of short-term and long-term priorities, and you come up with a very standardized, well-recognized hit list, if you like, of research priorities. And I think that would probably be useful for all of us. But it also means that you have something very formal that you can present when you go for grant funding. You say that this is the top priority of from a very formal process. So I'd be happy to follow up on some of those things, but that might be very worthwhile doing. So anyway, I mean, I'm happy to pick up some other comments after, and you know, I think just to briefly weigh in, I think while things like setmelanotide may not, I mean, tiny numbers in Alström, so I don't think you can overinterpret that. But I very strongly think that anything which is used, if you like, as an obesity therapy will be very effective in Alström, whether or not there is strict obesity. And that's because people with Alström behave as if they're much more obese than they are. And lots of the complications are very exquisitely sensitive to effective therapies. And so probably the easiest win is to look, I mean, you mentioned liraglutide and some of Pietro's programs, but the most exciting medicine on the market is tirzepatide, which is just being licensed in the UK at the moment, which has the biggest effect of all so far. So those are the sorts of things which could be in a priority setting partnership to work out the smartest way to try those things early. And my very final point would be that you don't always have to do a fully blown, expensive randomized controlled trial. And because of all the focus on rare disease work, people are very interested in using information in smarter ways to get the same results. So sometimes using information from real world databases, which of course is brilliantly done in Birmingham. And sometimes there's some very clever designs of trials in rare disease, which don't involve as many people as you have. So I think there's lots of exciting stuff going on and lots of reasons for optimism. But what you also have to do is back the best candidates. And that's partly where using mice to sort of choose which things you're going to try comes in. And that's where I'm going to introduce Eleanor, who's been doing a BHF, British Heart Foundation funded PhD in my lab, just finishing off and is in the middle of writing. So I'm sure she's very pleased to escape from writing to come and actually speak to some people today. And she's done a lovely job, which has taught us some things, but also positions us really, really well to now push on and go for some of that rare disease funding together with colleagues in Birmingham. So I'll hand over to Eleanor now, and she and I will be happy to take questions at the end, although I'm very worried about the missed yoga as well.
Thank you very much, Rob. Yes, as Rob mentioned, I am a PhD student up in Edinburgh working with Rob, and I've been using mice as a model of Alström syndrome to look at heart failure and diabetes. So a kind of quick summary of why we study mice. So we have been there's been a lot of characterization of patients that people have really kindly participated in a lot of studies. So it's quite well understood what is happening in patients, but what we don't really understand is why that's happening and what the mechanisms are. And one of the great things about mice is that you can do more mechanistic studies you can't do in humans by looking at taking out organs or looking at them in different ways. So it's quite a nice model to do in that way. Also, mice have a much shorter lifespan, so you can look across the whole lifespan over 1 or 2 years in a much quicker way than if you're trying to follow patients over decades and decades. And they're really good for testing out potential drug targets and other things before we have to kind of put patients through things like painful biopsies or kind of going on a drug trial that might have side effects. We can potentially see if that drug will be before. So some people might know that there are already some mouse models of Alström syndrome. So I'm sure you all know that the gene ALMS1 is mutated in Alström syndrome. And mice also have this same ALMS1 gene. And it has been deleted by several different scientists in the past. And the features of these mice recapitulate quite a lot of the disease, the human disease. So these mice have vision loss and hearing loss, increased fat mass and diabetes. But one of the things that hasn't been looked at so well is the heart failure. So one of the first things that I was looking at in my project was, do ALMS1 knockout mice, so mice that kind of effectively have the same mutations as patients, do they show heart failure? And can we use this to unpick the kind of infant cardiomyopathy and that cardiomyopathy that can be seen in adults? So the way that we did this is something that some of patients and families might be familiar with, which is the echocardiography. So that's using ultrasound to look at the structure and function of the heart. And we do this similar to patients. We scan the mice and we can then look at the heart and analyze, are there changes happening? So we did 2 different studies to look at mice. We did a study which was the neonatal study, and that was looking at young mice. And so the equivalent age, these were about 2-week-old mice, and that's equivalent about to a newborn in humans kind of age. And then we did an adult study where we looked at echoes at 8 weeks and then at 23 weeks old, and that's equivalent to about a teenager and someone who's about 30 years old. So the results that we got in this study were that we did not see any evidence in the mice of heart failure in the young mice, and we also didn't see any heart failure in the teenage mice. So that's a bit disappointing that it wasn't, doesn't seem to be a good model. It doesn't seem to be the same as what's going on in the humans. But we did see some differences in the heart function at the 30-year-old equivalent time point. But interestingly, we only saw this in the female mice and not in the males. And that's something that we're still a bit puzzled by, but we're investigating further to see if we can understand why that might be happening. So in the conclusion from this heart part of my study was, unfortunately, the mice don't seem to be an easy model of the heart failure in Alström syndrome. But that doesn't mean that they might not be useful at all. There are further things that we can do to kind of see if we can kind of really discover if there's something going on in the heart by using different drug treatments in the mice. But it also tells us that there are other options going on that might be kind of a good place to put our future energy. So as Rick mentioned, there's Katja Gemlich in Birmingham who is working with human stem cells to look at heart function. And so that definitely is a really exciting thing to be looking at in the future for understanding heart function. So the second part of my study was trying to understand why diabetes happens in Alström syndrome, why it happens so early and so severely in patients compared to people who don't have Alström syndrome. And based on some previous studies and other evidence, for example, some people who've kindly given fat biopsies in the clinic in Birmingham, we know that fat is important in Alström syndrome, and we think that might be one of the reasons that diabetes is so severe. So why do we care about fat? So as I mentioned, we've been able to look at some biopsies of fat from patients with Alström syndrome, and there's a lot of evidence of damage in this fat tissue. And we also know that fat is very important for health. So people often think that fat is bad, but you actually do need a certain amount of fat to store excess energy. Because if you cannot properly store kind of excess energy, then it can't stay in the fat tissue, then it ends up going to tissues that aren't designed to store this. So that could be the pancreas, that could be muscle, and that could be your blood vessels. And when you have fat tissue in these places where the tissue isn't designed to store fat, that can cause things like diabetes, insulin resistance, and atherosclerosis and kind of further heart disease. So we decided to look at fat specifically in mice with ALMS1 mutations. And one of the exciting things that you can do in mice is that you can't do in patients is you can specifically cause mutations only in some tissues and not in others. So it's already known that when mice have mutations in ALMS1 in all of their cells, that they have increased fat mass and diabetes. But to understand the role that fat tissue is playing in the diabetes, we knocked out ALMS1, so we deleted the function of this ALMS1, similar to what happens in Alström syndrome, only in fat cells, while there's normal healthy function of the ALMS1 gene in other tissues. So the results that we saw here was that when these mice only have Alström syndrome mutations in their fat tissue, they still develop diabetes. So that tells us that the fat is very important in driving the diabetes that we see in Alström syndrome. Also, these mice still have a very fatty liver, even though ALMS1 is working normally in the liver. So this tells us that the higher accumulation of fat in the liver is caused by the failure of the fat tissue itself. It's not necessarily driven by the liver having not worked. Also, these mice don't have a lot of fibrosis in their fat tissue. So this again comes back to what Rick and Rob have mentioned, is that we don't think that the fibrosis is causing the insulin resistance and diabetes, but is actually an attempt by the body to try and repair the damage that has already happened in their fat. So in the future, as Rob mentioned, I'm just writing up my thesis at the moment. So after I finish that, Rob and I will be writing 2 journal articles, one looking at the insulin and insulin resistance and diabetes, and one looking at the heart. So they will be published. So then when people do future research, they'll be able to refer to that, and that helps kind of build the literature up. And Rob is also definitely looking into future grants to further this research. We've still got these mice in Edinburgh that can be used for many future studies. So there's a lot of exciting things that can still be done. So just to finish off, I'd like to thank Rob for being such a good supervisor and the rest of my team. And as Rob mentioned, I'm funded by the British Heart Foundation, and Rob is also funded by the Thank them. Thank you.
Oh, thank you, Eleanor. Okay. Oh gosh, I had a panic then. It wasn't working. Good to see you. Eleanor, are you happy? Do you want to take questions now, or do you want to take questions at the after next session? It's up to you.
Very happy, whichever you prefer.
Okay, right. So I'm going to pass over to Catherine to ask some questions. I know Robert got some. Just going to kind of suggest some answers to some of the questions that came up earlier. I'm going to pass you over to Catherine to ask some of those questions, if I may, only because I can't see very well at the moment. Catherine?
I haven't had any questions come up in the Q&A session. Let me just have a quick look in the chat, but I don't think anything had come through. Have you seen anything, Kerry, come through on the chat box?
No, but I'll ask a quick question.
Oh,
so,
go on.
Yeah, just thinking about next stages then, Rob and Eleanor, where do we go next? And if, you know, if money wasn't an object, where would you want to go next? With Alström, obviously.
not Barbados.
Oh.
So I guess that's maybe more of a problem for me, unless you'd like to answer, Eleanor. So I think you know, it's very odd. People have been studying mice to try to understand Alström syndrome for a lot of years now, but nobody's ever really clearly described what their hearts are like. And so finally we've done that, and we've shown that they don't have the heart problem of Alström. So that's sort of disappointing, but it's very useful to know. It might tell us something, because as Eleanor said, these mice don't get fibrosis, and mice are not very good at getting narrowing of blood vessels. So they don't get those two things, and they don't also get heart trouble. So maybe that tells us that those are important in that. So I think it helps us in a grant on the cardiovascular side, I think, is very important. And I think we need to do that together with Rick and Katja, and the work that Katja is doing working on human cells, I think, becomes particularly important. There's certainly things that we can do with the mice, but it helps us understand what we can and can't do. So I think the sensible thing is probably to have a grant focusing on the heart. I think on the fat side of things, there's some very obvious things that we want to do coming from our work. And I think the smart way to use these mice is, as I said, to try to use them to prioritize what the best bet is for trials. Because of course, Alström is so rare, there are not that many people around with it, and you have to make choices. You can't do trials of everything. But you can learn these things very quickly in mice. And as we know, they show all the metabolic problems and the scarring and damage of the liver and diabetes of Alström syndrome. We can test a raft of things quite quickly over 2 years in the mice and use that to decide which are the best bet to go for in clinical trials. So I think the smartest thing would be to put together a grant application with some rare disease funding which doesn't even need to eventually describe what the ARMS1 protein is doing. It needs to be focused on the most important problems, which is finding the best treatments. So I think we've got a roadmap to do that now in a sort of 4-year research grant, which I think we'll be able to write up in the as soon as Eleanor's finished her thesis in the spring. So.
No pressure.
Excellent, thank you. There's a question coming in the Q&A box. So, hello, have you studied in mice with Alström the possible incidence of GLP-1 analog drugs in fatty liver or in any other parameter?
So I'll tell you what I think about GLP-1. So I work a lot on other genetic conditions as well, particularly ones which mean that fat tissue doesn't work, and that's the only problem. And from a metabolic point of view, they look identical to Alström syndrome. They get nasty diabetes, insulin resistance, and liver scarring and early heart disease. And in those conditions, if fat is not able to do its job properly, then anything which takes the pressure off fat and means you're not trying to store so much energy in fat does a lot of good. And that's exactly how GLP-1 agonists work. And there are a whole variety of GLP-1 agonists. So I think we almost have enough information that they should be, one of the mainstays of care at the moment. Again, it's always difficult in rare disease because you often are not guided by clinical trials. You often don't have a specific license for that rare disease. So there is a gray area where doctors have to be making a judgment call. But as I mentioned in the chat, there are some. The whole world is trying to make better GLP-1 type drugs by putting them together with other things. And there's a lot of drug companies doing this. And the one which is most exciting at the moment is a GLP-1 stuck onto something else. And that's producing by far the biggest weight loss in common types of type 2 diabetes. So I don't think it matters whether it's anything to do with the Alström protein specifically, but anything that helps to turn off appetite and means that the fat tissue works less hard will do a lot of good. And if you take the pressure off the fat tissue, you also take the pressure off the liver, because we've shown that even if there's nothing wrong with the liver, it still gets very fat and damaged if the Alström protein isn't in the fat tissue. And it also shows that happens without it being in the lymphocytes in the white blood cells as well. So I think that's maybe where some of the easiest wins are to be had, to really look at all these types of drugs which help which are being developed for obesity and type 2 diabetes, pick the best ones, and then try those in Alström syndrome. But maybe trying those in mice first will be very helpful to make the case. So.
Excellent.
Thank you.
I have
Christopher's just asking if you can please repeat the name of the medication.
Yeah, I think it's higher up the chat already, but I'll put it in the chat again. But I think it's only just been licensed in the UK for type 2 diabetes, and so now it gets evaluated by NICE for use in common type 2 diabetes. But there's a lot of excitement about it in the field as the most effective drug around at the moment. So it's very new.
Perfect.
I had one thing to add, actually, in response to the question about if I had infinite money, what would I do? And it's actually something that I read in the Southern paper, which was using translational read-through drugs. And that would be something that could be potentially tried in mice. And if that would be my dream study to be able to do.
Eleanor, I'm really sorry. I didn't hear that. It came in and out. Would you repeat it, please?
Of course, sorry. That was just, if I had infinite money, one of the things that I'd like to do is actually linking up with something that Jonathan has published, which was they've used a specific type of drug that means that you can read through the gene. And I think that will be exciting to try that in mice.
Fabulous.
I've got one more question from Michelle. Can I just ask that one on?
Yeah.
There's so much variance with the Alström population. Why does everyone not follow the same path clinically? My daughter, for instance, is not bothered about food whilst others are.
Good question.
So that is a common question in a lot of rare inherited diseases. And what people often say is, well, why do we all look different to each other as well? So although you have one bad change in a gene which causes a particular disease, it doesn't mean that all the other hundreds and thousands of changes in genes we have which make us different to each other will decide how your body responds to that one bad change, if you see what I mean. So there are other things which will change that course. Also, what we did when we studied skin cells from people from Birmingham as part of the EuroWAB and the DAS study, we showed that some of the people who had slightly milder or later problems than other people were still making a tiny amount of the protein, even though they had the damaging changes in the gene. And that's really what Eleanor is talking about. So the body sometimes can sort of bypass damaging changes in the gene. And some of these new medicines that, these experimental medicines, which Eleanor talked about, are designed to increase the amount of that, because maybe you don't need to increase it very much to do a lot of good. Maybe if you go from making no Alström protein at all to making 10% of normal, that could have a big effect. So it's a really good question, and it's one that's asked in all diseases. We have to wave our hands a bit and say it's because we're all different to each other. It's a very, very difficult thing indeed to study, to try to find out what those other gene changes are, and it probably won't be possible in Alström on its own.
Okay, perfect, thank you. We've just had another question come in. If Catherine or Kerry can read it, it's in the chat box, please. Thank you.
Rob, in my clinical experience, you're testing me now, Ozempic and other GLP-1s have been very successful in AS as well. I think it is to the point where they should be considered first line for people with AS. What are your thoughts?
Yeah, so I sort of agree with that. It's that very difficult area, because if you work by the very strict rules set by the licensing authorities, really we're supposed to wait till drugs have a particular license for a particular condition. But in conditions such as diabetes or obesity, you know, to be brutal, the companies that make these drugs don't really care about very rare diseases, because they make all their money from the common diseases. So that means that it's quite unlikely you're going to get a license for a particular disease. So that means it falls back on the expert doctors who look after it to discuss with patients and make their own judgment call. So you always have to have those disclaimers. But yeah, if I'm going to nail my colors to the mast, I would be using those as one of my first choices. Together. I mean, I don't have personal experience of looking after Alström, but the other tablet, of course, which is appealing, are the SGLT2 inhibitors, which are beneficial for heart failure in other settings as well. So I would be going to people like Rick and asking them what they knew about that. But yes, I think it makes immense sense to be prioritizing those medicines in Alström syndrome.
And just a follow on from that, should that only be Aisha just asking, should that just be for Alström patients with diabetes or not?
So I can answer that. We give everybody who's got any evidence of diastolic dysfunction or stiffness an SGLT2 inhibitor. We've done that for a while. The only difficulty is the two that are given at the moment that have evidence base in are empagliflozin and dapagliflozin. So one of the slight problems is that if you then add on to things like semaglutide, so some people are on there, you can increase the risk of diabetic ketoacidosis in some patients. So they've tended not to be co-prescribed.
That question came from somebody in America. Well,
May I ask a follow-up on my previous question?
yeah, sure, Chase. Yeah.
Yeah, so like at the multidisciplinary clinics we've done, Chase from ASI, in the States, it seems to me that it's a pretty common recommendation we've found to be using the, to speak to Rob's point about he doesn't follow it that much. In my experience, we've had tremendous results with GLP-1 use in Alström syndrome. I mean, obviously all anecdotal, but like anecdotally people losing 10 pounds, in 3 months or something, or 20 pounds in 3 months. I guess that's like 5 or 7 kilos. And also the increased satiety seems to be a huge factor too. It gets rid of the hyperphagia for some people nearly immediately, like within a week.
And it's a good point about whether or not you have to have diabetes, because some of these medicines are licensed in quite high doses in large parts of the world to treat excessive weight, even without diabetes as well. And that would, I think, almost certainly work in people with Alström who were insulin resistant and were showing the signs of heading towards diabetes. But again, as you move away from what the license is, I think it's just important there that the doctors speak openly to the patient about the pros and cons and uncertainties and make an informed choice. But certainly I would be in the side of being quite early and quite strong with GLP-1 agonists.
In the UK, is it indicated in just obesity? Because, for example, under the brand name Saxenda in the States, semaglutide is indicated in anyone that has like an obese BMI.
Yeah, I think we're a little bit behind you, but yes, it is licensed now.
It's licensed for a specific BMI plus risk factors.
There's a really important point there, and this is something that's true in these other lipodystrophy conditions. A lot of in the common types of disease, BMI is a critical threshold for treatment. But if you have a condition which means you aren't able to expand your fat tissue properly, you can throw those BMI rules out the window, because you can behave as if you're somebody who is severely obese, even if you're not obese at all sometimes. So what you should pay attention to much more is whether there is insulin resistance and fatty liver and high triglyceride levels. And if those things are all there, that tells you the fat tissue is overloaded, it's not working, and you need to take the pressure off. So I think one of the key lessons is to ignore the usual BMI rules and pay attention instead to the evidence that the fat tissue is overloaded.
Sorry, I was just explaining. NICE have put a BMI rule for prescription in the general population. Semaglutide is still being given to everybody in Alström. I also just think it's really important that actually just losing weight is not enough. So semaglutide's fine and losing weight's great and all of the added metabolic benefits. But just because you lose weight doesn't mean you should give up on the exercise and diet that Pietro has been talking about. So it's really important to make sure, you can be skinny and metabolically very unhealthy and still get accelerated cardiovascular disease.
They're part of the two sides of the same coin.
And one just final thing in the chat box. Who's gone off somewhere? Kerry from JJ. Mom, can you see it
in the Q&A? Hang on. Talking about diabetes, I'm not sure it's all down to food, as my lad was only on water and the sugar levels still went up and down after a 24-hour period. Over a 24-hour period.
Yeah, over a short term, remember, lots of hormones change over a 24-hour period, and some of those hormones push up sugar as well. So it's in a short time period like that, you will get natural changes in blood glucose if you're very insulin resistant, even if you're not eating. So it's a good point. In the longer term, though, the way to improve all those things is to take the pressure off the fat tissue.
Perfect. Okay. I'm going to draw that to a close. Just aware of the time. Thank you very much for that, Rick. Thank you very much, Rob. Thank you very much, Eleanor.